Welcome to the next session of the Public Health Surveillance course. I'm Dennis Nash, a professor of epidemiology at the CUNY School of Public Health, and the focus of this session is historical context, developments in the understanding of disease causation. The goals of this session are to explore the historical context and how our understanding of disease causation evolved over time. We'll see how the desire to understand the causes of diseases and epidemics gave rise to the field of epidemiology and one of its key subfields, public health surveillance. The historical context will help set the stage for the rest of the course in public health surveillance. So epidemiology is about understanding the distributions and causes and determinants of disease. And in many ways, it was out of the desire to understand more about these causes of diseases and the epidemics that flowed from them that the field of epidemiology was born and went on to reach its current form today. Epidemiology is the study of the distribution, causes, determinants of health-related states or events in specified populations, and importantly, the application of this study to control and prevent health problems. So we're interested in things like what causes disease X? Does exposure A cause disease X? And can we prevent disease X from occurring? This is what defines the field of epidemiology today. But while epidemics of diseases have existed for millennia, epidemiology has not. And in this section of the talk, I'll try to describe how our understanding of the causes of disease and epidemics have evolved over time, including before the advent of the field of epidemiology. Let's take a look at what we've learned about the causes of diseases and epidemics over the centuries, or how at least these causes were understood at different time points in history. One common theme, perhaps not surprisingly, is that disease and death were brought about by supernatural causes, such as the wrath of God. I've included a quote from the book of Exodus in the Bible here that says, "For now I will stretch out mine hand that I might smite thee and thy people with pestilence." In other words, an overwhelming epidemic of disease. This quote makes clear the belief in supernatural causes of diseases and epidemics. You can also see this theme about supernatural causes of disease reflected in this 19th century painting depicting the horror of a plague outbreak ravaging Rome. Here, an angel comes down and points to the door of a house where the next case of plague should occur, again alluding to the belief that diseases and epidemic spread was determined by supernatural forces. But that's not to say there wasn't evidence of rational thinking about the causes of disease as well. As early as 400 BC, we can see in Hippocrates' writings in the Epidemics that he rejected the notion of supernatural causes of diseases. In fact, he related symptoms of different illnesses to things like seasons, geography, soil, and nutrition. Something that wasn't quite right in his thinking, though, at least with regard to infectious diseases, is that he conceptualized illnesses and persons as unique events that were not necessarily related to each other. Of course, we know that with infectious diseases, one person's illness is often highly correlated with the risk of illness in people they come into contact with while they're infectious. Importantly, Hippocrates also coined terms that we still use today, endemic and epidemic. In some ways, without the field of epidemiology to gain insights and serve as a guide, it's understandable that the causes of disease and outbreaks were not immediately obvious. The causes of disease are often complex and involve multiple steps. Infectious diseases are not always simply spread from person to person. For example, in the case of plague, when an infected rat is introduced to a household, other nearby rats are quickly infected by the fleas that infest and feed on them. However, the rats die, and the plague bacillus or bacterium in the infected rats prevents the fleas from digesting the rat blood that is their source of food. So the fleas start to look for other sources of food, like humans. When infected fleas were introduced into a household, plague killed on average 50% of the household residents over the course of a few weeks. Another 1 in 4 household members would be infected but survive, and the final 1 in 4 do not become infected. To complicate things, when people are infected with the plague, They developed the bubonic form of plague, which is not necessarily contagious. However, in some instances, plague infection can spread to the lungs and cause pneumonia, leading to the pneumonic form of plague, which is highly transmissible from person to person and rapidly fatal. We know all of this now, but the role of rats and fleas were not appreciated as a cause of plague, even though large numbers of rats were observed to coincide with plague epidemics. This late 17th century painting depicts bubonic plague. It conveys the fear, abandonment, loss, uncertainty, and pandemonium that must have accompanied the plague outbreaks at the time. But it also conveys a lack of understanding about causes. At that time, it was thought to be caused by bad or noxious air, not the bite of an infected flea or respiratory droplets from an infected person. You can see here in the picture the dark cloud of noxious air circulating in the room. And also people covering their noses and mouths with cloth masks. Miasma theory, prevalent in ancient times and persisting through the Middle Ages into the 19th century, is that diseases were caused by a form of bad air or polluted air. This noxious form of air was thought to arise from rotting organic matter, swamps, waste, or other decomposing materials, including dead bodies. And it was believed to be the cause of various illnesses, particularly epidemics like cholera and the plague. The term miasma itself comes from the Greek word for pollution. The miasma theory was a dominant explanation for the spread of disease before the development of modern germ theory, which demonstrated that specific microorganisms are the causes of specific diseases. Today, we understand that many of the diseases attributed to miasma are actually caused by bacteria, viruses, or other pathogens that are spread through direct contact, respiratory droplets, contaminated water or food, or other vectors like mosquitoes, ticks, or fleas, rather than by bad air emanating from decaying matter. But clearly there was a notion of person-to-person spread of diseases in the time of plague, though this was not how bubonic plague was spread. As early as the 1300s, authorities in Venice began boarding incoming ships to port that were coming into, and they were boarding the ships to identify the people who were ill on board and prevent them from disembarking. This is actually an early example of the public health strategy of isolation. Authorities did this by routinely looking for or surveilling for possible plague cases for the purposes of controlling and preventing disease in the community. It's an early application of public health surveillance. Eventually, Venetian authorities prevented all persons on board from disembarking from the ships coming into port to Venice, regardless of whether they had symptoms. They made them wait for a period of 40 giorni, or 40 days in Italian, to see if people on board developed illness. The practice was called quarantino in Italian, and it's the genesis of the term quarantine that we still use today. These two very different strategies, isolation and quarantine, are two important public health measures to control the spread of infectious diseases. And the distinction is that isolation focuses on people who are ill with symptoms or are known to have an infection, whereas quarantine focuses on all persons who may have been exposed to a given infection, regardless of whether they have symptoms. Public health surveillance plays a critical role in both of these strategies. However, in the case of plague, without an appreciation for the role of rats and fleas, who could move freely from boats to land, the strategies of isolation and quarantine was ineffective. While the communicable nature of diseases was appreciated, the epidemiology and mechanisms were not well understood, and this led to flawed disease control interventions. This underscores how fundamentally important it is for public health practitioners to understand causes of disease and disease spread, so that we can adequately design the interventions and strategies that help us attain the critical goals of disease control and prevention in populations. Moving on to some other historical developments, in another departure from miasma theory, Fracastoro, an Italian physician and Renaissance person, was one of the first to hypothesize that infections were spread from person to person by conceptualizing minute invisible seeds or seminaria that were unique for different diseases. He said that seminaria were self-replicating and acted on the humors of the body to create disease. This was a prescient thought, as this theorizing about the causes of disease was happening prior to germ theory, before it was known that there were microbes and living organisms that were the causes of different diseases. He further suggested that these seminaria could be transferred between infected and healthy individuals through direct or indirect contact, or even over a distance, what we now understand as airborne transmission. However, he was a little bit off by saying that seminaria were related to planetary alignment, which was perhaps an interpretation of seasonal disease patterns. It was actually commonplace for astrology to be integrated into medical practice at that time. Fracastora went on to also posit that there would be 3 modes of transmission of these seminaria: person to person, fomites, and airborne, with fomites being inanimate objects on which the seeds, in his case, or actual microbes, would be conveyed from a source to a susceptible individual who could become infected. So these were pretty important conceptual developments in the 1500s. Incidentally, in true Renaissance fashion, Fracastora wrote a didactic poem describing in great detail the symptoms of a shepherd with a dreadful disease. He described how the disease was spread throughout Europe following the movement of French troops. For this reason, the disease was often called the French disease, and what we know today as syphilis, which is the name of the shepherd in Fracastora's poem. In the 1600s, Thomas Sydenham argued that all diseases ought to be reduced to certain and determinate kinds, similar to the way that botanists would do with their treatises of plants. Many of you have probably seen these detailed drawings of plant species that really help differentiate one species from another. Sydenham thought that the same should be true for different diseases, that diseases would be distinct from one another. This notion spurred thinking about how distinct diseases might also have distinct causes. So this was an important conceptual development. Another important development in the 1600s was when Petty and Grant began to use data to describe patterns of mortality. This was thought to be one of the first applications of statistics. London was made up of administrative units called parishes, and each parish was responsible for tracking births and deaths among its members, and routinely post that information on a bill. Petty and Grant gathered this information or data from each parish in London on these so-called bills of mortality, which allowed them to tally the number of births and deaths, and in some instances even the causes of death, for each parish and all of London. After doing this, they realized how important it can be to monitor these kinds of things, and they proposed the establishment of a central government agency responsible for collecting data on vital information on births and deaths going forward. They published a very important book called Observations on the Bills of Mortality, where they analyzed these data and presented their results. So each parish would routinely post these bills or written details on the number of people who were born and number of people who died in the parish. And the bills from each parish would be gathered and the data compiled and summarized as shown on the right. So here, the year being 1632 in London, they reported that there were 9,584 people christened, which corresponds to births in England at that time, and 9,535 people buried or died. They had a very crude classification system, mainly because the understanding of diseases and their causes was very limited at the time. However, a lot can be learned by combining like with like, even if they are not much is known about the causes. So what did some of their data show about mortality in 1632? It was not a big plague year in London, only 8 deaths. However, there were causes that were much more common, including infectious causes. Here you can see consumption. Almost 1,800 of those deaths were thought to be due to consumption, which is tuberculosis. And another 1,100 or so are due to fever, which could be a variety of different infectious causes. And here we have flocks and smallpox at 531. There were over 2,000 infant deaths, and these were referred to as chrysomes. That is, they died within a month of being baptized. A chrysome was a sacred baptism cloth that infants would be buried in if they died within a month of baptism. So that's where the name comes from. And here we also see some deaths from syphilis listed here as French pox. Using the data that they compiled from all the different parishes this way, Petty and Grant were able to make the observations such as 36% of all live births resulted in death by age 6, or that males were more likely to die from violence, war, and other causes as compared with females. They could analyze time trends and the number of deaths in London over the preceding third of a century to look at the seasonality of deaths. And they could also compare mortality rates by urban versus rural settings. These kinds of analyses and comparisons can provide insights and hypotheses about what the underlying causes behind these different causes of death might be. In the 1700s, Morgani used autopsy studies, which included detailed accounts of the symptoms that people experienced before they died, which are then investigated after death as part of an autopsy. Using this approach, it was possible to correlate the signs and symptoms observed in the patients with the specific post-mortem pathological findings in the tissues and organs during autopsies. This was another example that spurred the search for specific as opposed to general causes of diseases, and another example of the idea that each disease might have its own specific cause, since each disease has its own specific set of symptoms and pathology. Another important observation is with regard to smallpox, also known as variola. Smallpox infection was observed to confer immunity among its survivors. That is, while smallpox infection killed many of the people it infected, those that survived did not appear to be at risk for becoming infected with smallpox after subsequent exposures to the virus or during outbreak situations. Recognizing this, people would take the scabs from smallpox survivors and use them to inoculate themselves as a means of protection. It's an early example of the notion of vaccination, or as it was called at the time, variolation. It's a practice that had been done, in fact, centuries prior to the 1700s in Africa, China, and India. However, in the 1700s, as the apocryphal story goes, Edward Jenner had the observation that milkmaids, people who milked cows, were immune to smallpox infection. This was possibly, he hypothesized, because they were exposed to the cowpox virus or vaccinia as part of their work. And to test this hypothesis, he inoculated an 8-year-old boy with the cowpox virus, and then, after an adequate time had passed, he exposed the boy to the smallpox virus, twice in fact, to see if he would develop smallpox infection. This is obviously an experiment, a challenge experiment, that would be considered highly unethical by today's standards. But it was done, and luckily it worked. The boy didn't develop smallpox, and the science of vaccination was born from this unethical clinical trial. Vaccination comes from the name for the cowpox virus, vaccinia, which itself is derived from the Latin word for cow, or vacca. In fact, while some parts of this story are true, several people have had the important insights that contributed to the invention of what we ultimately know today as vaccines. It wasn't just one person, as the story of Jenner would have you believe. This happened because of the many people who independently practiced variolation, which had effectively been going on, as I mentioned, probably for centuries in Africa, China, and India before Jenner's experiment. But smallpox, which killed unbelievably about 300 million people in the 20th century alone, was eventually eradicated using vaccination. In the 1800s, that recommendation that Petty and Grant had put forward in the 1500s about establishing a central government office to register births and deaths didn't quite happen right away. But by 1831, the government of England finally saw fit to establish such an office, and the General Registrar's Office of England was headed up by William Farr, beginning in 1838. This new office was responsible for capturing information on the vital events of births and deaths. As part of this work, Farr also developed a disease classification system that was more systematic and informed than the ones we saw on the Petty and Grant's observations on the bills of mortality. Farr's system had broad groupings. Here you can see the infectious diseases largely fall into a category called zymotic diseases, which were epidemic, endemic, and contagious diseases. And there were other groupings like different organ systems, developmental diseases, and violent deaths. Farr's office would gather and tabulate information on births and deaths like Petty and Grant did, and then, importantly, they would disseminate the findings of these tabulations to the general public on a regular basis. And here's an example of the 20th annual report from the Registrar General's office on births, deaths, and marriages in England in the year 1859. You don't need to get all of the details in the table here, but I do want to orient you to the structure of the table. In the columns going across, we have the year of death running from 1850 to 1858. And going down on the rows are the different causes of death, categorized or grouped. So zymotic diseases, constitutional diseases, local and violent causes, etc. Note here that Farr had a category for miasmatic diseases or miasma-related diseases. And these included the infectious diseases like cholera, typhoid fever, and smallpox. In each of the cells of the table are the number of deaths for a given cause and year. So looking at deaths from all causes in each year, at the top of the table, the number ranged from 300 to 500,000 deaths in any given year. Then we can see a number of deaths broken out by causes, so you can easily get a sense of which were the more common causes of death in England in a given year. And they changed. I just want to underscore a few noteworthy things from Farr's reports, which I've highlighted here. He wrote that perhaps the chief fact of all is not unworthy to be regarded with satisfaction is that of 449,656 persons who died, 440,922 did not pass away without leaving some record, more or less correct, of that last illness which sealed their fate. And it is near the truth to state that the nature of that illness was described by men professionally qualified to give the information in about 80% of the total number of deaths. So here he's pointing out that the cause of death is documented by a physician or other qualified person who could speak to what led to the cause of death most of the time. And that in turn speaks to the veracity of the data and the lower likelihood of misclassification, establishing credibility to the data summarized in the report. The bottom paragraphs that I've highlighted include some of the useful descriptions of the statistical summaries that Farr provided. For example, in the first paragraph, Farr describes that among those died, what proportion of deaths were due to different causes like zymotic diseases, accidents and violence, etc. In the second paragraph, Farr uses the denominator of all people in England who were alive in 1859 to get at really what is the concept of rates. So he says, out of 1,000 persons living in 1858, 6 died from diseases of the zymotic character, 4 from constitutional diseases, 8 from local diseases, 4 from developmental, while about 2 out of 3,000 living lost their lives accidentally or from injury willfully inflicted. William Farr was on to something when he developed these reports and statistical summaries. Here's a table that comes from our health department here in New York City and their annual report on vital statistics that they put out each year. The table format that Farr used back in the 1800s to summarize this information really still endures today. It's pretty much the same format, but what's different now, of course, is our disease classification system, our death classification system. It's more precise, it's more accurate, and more evolved because we know so much more about the causes of diseases and what distinguishes one disease from another. But the basic structure is the same as that used by Farr in the 1800s, as well as by Petty and Grant in the 1500s. These kinds of statistical summaries of mortality really help us understand what the major causes of death in populations, and they can be used to set public health priorities for disease prevention and control. Next, we're going to transition from early thinking about causes of disease in individuals into one that's more about epidemiologic thinking around disease causation in populations. Indeed, this was the next logical step, since it was increasingly common for people to have theories about the causes of diseases that couldn't really be tested without carefully observing what happens with disease spread in populations. And since you're taking an epidemiology course, you've probably heard of John Snow and his discoveries around the causes of cholera pandemics. These are what gave birth to the epidemiologic method and the process. Cholera was, in fact, a major cause of epidemics and death in England in the 1800s. And Farr and Snow were contemporaries. They did much of their work prior to the advent of germ theory, that is, the theory that microorganisms too small to see with the human eye were a cause of infectious diseases. William Farr, the general registrar, believed that miasma, or bad air, was the cause of many infectious diseases, including cholera. And John Snow, an anesthesiologist, was a skeptic of miasma as a cause of cholera. At the time, Farr rightly argued that even if the ultimate cause of an epidemic is not known, the mode in which the epidemic operates could be determined through observation, with the potential to ultimately prevent or control epidemics. And this is exactly what Snow set out to do to understand the cause of London's cholera epidemics and ultimately put a stop to them. Before investigating all of London, Snow started by investigating and describing the outbreaks of cholera in London's Soho area. He determined that they were associated with a contaminated well on Thomas Street in Soho and a burst drain from Albion Terrace, and he then detailed an initial account of 89 deaths from cholera. People who died had drunk or bought water from the Broad Street pump, and those who had other sources of water or drank beer, like the workers adjacent to the brewery there, did not get cholera. Here you can see a spot map of Soho with the number of cholera deaths by household that Snow created. Importantly, Snow investigated exposures among those who had the disease, as well as those who did not have the disease. And from these observations and the knowledge that the water was supplied to Londoners from different water supply companies, Snow generated a hypothesis. The source of water or the water supply company that served each household would be associated with the risk of death from cholera. In fact, a better scenario could not have existed for Snow to test this hypothesis, because in many cases, two adjacent households would receive water from different water supply companies, and he immediately grasped the strengths of this natural experiment that these circumstances provided. And in Snow's words, he said, "To turn this grand experiment to account, all that was required was to learn the supply of water to each individual house where a fatal attack of cholera might occur." For each district, using the death registration information gathered by Farr, Snow compiled deaths from cholera in 1849. He combined that with information on the number of people in the population living in each district to compute a rate of cholera deaths per 10,000 inhabitants. Finally, he noted the water companies that were supplying the water to each district. You can see in this table that the number of cholera deaths per 10,000 inhabitants is calculated, and the table is sorted from high to low on that number. And this identifies the London districts that were most affected. The Soho area of London was in the Westminster district. And finally, you can see the information on the exposures, the water supply company for each district on the right. And this is just showing the remainder of that table, sorting all the way down to the district with the lowest cholera death rate. There were about 2.2 million people living in London in 1849, about 14,000 deaths from cholera for an overall estimate of 62 cholera deaths per 10,000 inhabitants across the entire city. So you can see how it really varied from one district to the next. And Snow compiled this information, the deaths from cholera, and ultimately looking at it at the household level, and compared the death rate per 10,000 households for the Southwark and Vauxhall Company to that of the Lambeth Company. And you can see that there was quite a big difference here in the rate. The slide shows those results graphically, and the household served by the Southwark and Vauxhall Company had cholera death rates that were an order of magnitude higher than the households that were served by the Lambeth Water Company and those serving the rest of London. It turned out that the Southwark and Vauxhall Water Supply Company got their water from the Thames River downstream of London, along with all the sewage from the city. whereas the Lambeth water supply company got its water from the Thames River upstream of London. So without the advantage of germ theory and laboratory methods, Snow was a pioneer in the development and application of epidemiologic methods when he used them to identify the downstream cause of the cholera outbreak and eliminate it by the symbolic removal of the Broad Street pump handle. He hypothesized about an exposure, which was contaminated water, and he systematically compared the risk of the outcome, in this case death from cholera, in those exposed and those unexposed, thereby giving birth to the epidemiologic method. This was a big blow to miasma theory as a cause of cholera and other infectious disease outbreaks. Snow said, "I believe that the poison of the cholera is either swallowed in water or got directly from some other person in the family or in the room. I believe it is quite an exception for it to be conveyed in the air." So Snow, who studied these great cholera epidemics in London during the 19th century, said, "But all of the above circumstances are quite sufficient to show that cholera can be communicated from the sick to the healthy, for it's quite impossible that even a 10th part of these cases of consecutive illnesses could have followed each other by a mere coincidence or without being connected as cause and effect." In fact, much of our understanding of disease causation and epidemiology today is actually rooted in these experiences with infectious disease outbreaks. And I just want to highlight again that this work was done prior to germ theory, showing that it's possible to prevent and control disease and outbreaks even when the biologic agent is unknown or not thoroughly understood. And this is what Farr meant, I think, when he said, if the latent cause of epidemics cannot be discovered, the mode in which it operates may be investigated. The laws of its action may be determined by observations, as well as the circumstances in which the epidemics arise, or by which they may be controlled. And those are the causes that epidemiology and public health are concerned with ultimately, and the risk factors that we need to manage. Indeed, germ theory didn't emerge until 1876, when Koch reproducibly transmitted anthrax from cows to mice. Germ theory and microbiology began to elucidate what Sydenham and Morgani posited much earlier, that specific pathogens were associated with specific disease entities. The discovery of germ theory promoted the biologic understanding of infectious disease processes in very significant ways, and subsequently, the Henle-Koch postulates were developed to provide proof of whether a particular microorganism is the cause of a particular disease. And these were later generalized to assess the level of evidence for causal associations in epidemiology. This slide shows the year in which different organisms were physically isolated and identified as causes of specific diseases. The bacteria that causes cholera wasn't identified until 1833, well after Snow's death. And if you've ever wondered where the E in E. coli comes from, E is short for Escherichia, and it's based on the name of the bacteriologist who discovered it, Theodor Escherich. That wraps up this lecture.